On today's episode of the Brain Health Kitchen podcast.
I always say genes are not your destiny. This gene is not your destiny by any means. ApoE4 increases risk slightly for Alzheimer's disease, but it really, again, depends on a lot of other factors. Unfortunately, people with high HDL, we now understand, have a higher risk of cardiovascular disease as well. So we stopped using good cholesterol for HDL, and if any doctors are telling you that, unfortunately, they have a little bit outdated information. So double check that.
Welcome back to the Brain Health Kitchen podcast. Jenny, today's conversation is one I wish everyone could hear before they start worrying about memory, genes, cholesterol, or the latest brain health trend online.
Exactly. This episode is for anyone who has wondered, is this normal aging? Should I be worried about Alzheimer's? Do I need to know my ApoE status? And what can I actually do now?
Yes, our guest is the perfect person to help us sort through all of that. Dr. Kellyann Niotis is a preventive neurologist who specializes in reducing risk for neurodegenerative diseases, including Alzheimer's disease, Lewy body dementia, and Parkinson's disease. And she brings serious credentials to this conversation. She managed the country's first Alzheimer's prevention clinic at Weill Cornell and now directs Parkinson's and Lewy body dementia research at the Institute for Neurodegenerative Diseases in Florida.
And Annie, didn't you recently write about early warning signs of dementia?
Yes, we just wrapped up a Substack miniseries about how to tell the difference between cognitive slips, which are a normal part of aging, and things that could be real red flags for dementia. And this is a lot of what we'll be talking with Dr. Niotis today. And in addition, what the role of new biomarkers like p-tau217 is. What I love about Dr. Niotis is that she combines rigorous science and real optimism. She helps us understand what preventive neurology actually means and why the brain changes behind diseases like Alzheimer's and Parkinson's can begin decades before diagnosis.
That's the big takeaway. Midlife matters. The earlier we understand our risks, the more opportunity we have to protect the brain. With the right information, the right questions, and changes that may actually move the needle.
Dr. Niotis walks us through early warning signs of Alzheimer's, Parkinson's, and Lewy body dementia, and what to ask your doctor to check beyond the usual labs.
And at the end, we put her on the hot seat.
Yes, we asked her to rate some of the wellness trends everyone is talking about. Sauna, cold plunging, creatine, omega-3s, NAD infusions, red light therapy, weighted vests, brain games, and more.
Basically, what's worth your time, what might help, and what you can skip. And for our paying Substack subscribers, look for bonus materials in the Substack post that goes with this episode.
This is such a useful, empowering conversation. Dr. Niotis gives us a clearer picture of what prevention can look like, not someday, but right now. After the interview, Jenny and I will return to review what we've learned and give you more practical advice for next steps. I hope you enjoy my conversation with Dr. Kellyann Niotis. I am grateful to have two of the most trusted brands in brain health as founding sponsors of this podcast. First, we are proudly supported by NeuroReserve, a brain health nutrition company dedicated to bringing us high-quality, science-backed supplements, including Relevate, a brain-specific blend of omega-3 fatty acids, and Revanta, a pure-grade creatine. In fact, if I had to personally choose just two brain health supplements to take, it would be Relevate and Revanta. Learn more about their commitment to brain health at neuroreserve.com and use code BHKPodcast for 10% off. We are also proudly supported by Better Brain, the world's first brain health and dementia prevention program that's covered by insurance. They provide a brain health panel of over 50 markers, expert coaching, and a personalized action plan. Most people pay nothing out of pocket. Check it out at betterbrain.com/Annie. So, Kelly, Dr. Niotis, it is such a pleasure to have you here.
Thank you, Annie, so much for having me.
Yeah, welcome to the podcast. I have so much I want to talk to you about, but we are going to start with you are a preventive neurologist, right? When I first found out about you, I think it was on Instagram or maybe it was through your work at Weill Cornell when you were working with Dr. Isaacson at the Alzheimer's Prevention Clinic, one of the few prevention clinics in the country. And I was like, why are there not more preventive neurologists? So, can you tell us a little bit about how you became interested in neurology, how you pivoted to prevention, which is not something that
Yeah.
we see very often?
Well, I will say that I'm a nerd. I really, really have always loved learning. I love school, and neurology struck me in a very different way. I loved how challenging it was. Everyone hated how confusing and all these neuronal pathways and circuits. And I just thought that was so fascinating how this organ could just control everything from our emotions to our behaviors to how we think, how we move, how we dream, all of that is our brain. And that to me was just such uncharted territory. And then when I started to get more into understanding the diseases and understanding specifically how neurodegenerative diseases like Alzheimer's and Parkinson's really start robbing you of who you are, it really hit me in a meaningful way. Um, my aunt has a very aggressive form of dementia, and seeing how that impacted not just her, but really our entire family. I'm Greek. Greek people have a huge family network and a huge community, and it really not only impacts the person who's suffering from it, but it impacts everyone around them. Hearing over and over again neurologists when I was working with them saying, your loved one has Alzheimer's or your loved one has Lewy body dementia, and we have some medications, but there's nothing that we can really do to slow down the disease course, just never really sit well with me.
Mhm.
And I did my own reading on it, and I actually found there is some people that were studying maybe what we could do, not just to slow disease down, but maybe even prevent it altogether. And that's how I stumbled upon Richard Isaacson's name. And I wrote him this email and I was like, I'm just this little medical student. Please, 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 please have me come spend time with you. And
This
I
was
went
in
to
medical
Cornell.
school. You were looking at
Yeah.
prevention in the neurology field, which is really unheard of. Like, how many years
Yeah.
ago are we talking?
This was over 10 years ago now. So it's like 12
Yeah.
years ago.
No one was saying Alzheimer's and prevention in the same sentence 10 years ago.
No. So I found that he started this clinic and it was really the first in the country. And I was just so desperate to understand him and what he was doing. And um, the rest was really history after that. I spent a lot of time with him. I obviously went on to train at Cornell and really learned that, when you're thinking about people who are at risk, who may not be impacted in any neurological or cognitive way, it's really hard to know, is this person on the path to Alzheimer's? Are they on the path to vascular dementia? Are they on the path to Parkinson's disease? And in neurology, we're just so siloed. We have our cognitive disorder neurologists and our movement disorder neurologists. And that's great because when people have Parkinson's disease, they need someone with expertise on how to manage the specific medicines that are needed for something like that. But when we think about prevention, we have to think back because the risk factors for Parkinson's and Lewy body and Alzheimer's, they're not exactly the same, but there are a lot of overlapping risk factors. And people who are at risk for one often have multiple in their family history. So you really need to think about neurodegenerative disease prevention more collectively. So that's when I decided, I need some more movement disorder training, and I did movement disorders, and I had a grand plan of coming back to Cornell to really expand the clinic there to build out Parkinson's prevention and Lewy body prevention. But the forces against preventive neurology have won right now in
Oh,
2026. But
I'm so sorry to
but
hear that.
hopefully,
So, how
it's
many people actually have the same training and background that you have as a fellowship trained preventive neurologist? Are you still the only
right
one?
now. Right now, none, but the goal, so I rejoined the faculty at Cornell in hopes of growing the preventive neurology fellowship. Likely will be a part of the cognitive disorder fellowship for now until we can get more of an established curriculum there. But that's the goal. So I hope that in the near future, there will be more of us. I think it's really not just that we don't have great training programs, we also don't have insurance reimbursements for preventive neurology services. So there's a lot of policy changes and a lot of other hurdles that need to be overcome before preventive neurology is really widespread in mainstream medicine. And just looking at something like preventive cardiology as this analogous field, it took them 20 to 30 years to really get going. So we're just at the very beginning.
Well, I have had a lot of people in my teaching and on my retreats ask me how to find a preventive neurologist. And I always say, well, as far as I know, there's only one. Her name is Dr. Kellyann Niotis, and you can follow her on Instagram. But she's the only one, and that will change. Someone has
There's
to
a
be her.
handful. There's a
Mhm.
handful, and I think more and more neurologists have reached out to me and asked for education, and I love that because I really think, like, there's just so much need, and I can't take on all of the need that's out there, and I think doing medical education and continuing medical education courses for providers will be a huge, huge piece of this puzzle of how do we get preventive neurology more widespread and more accessible to the masses.
So you are involved with resident education. You are seeing patients, and you're doing research still?
Yep.
Yeah. And
I
are you
have a full
oh,
plate.
you're writing a book. Tell us
I
tell us
am
more about the book.
the book will be entitled, we think, Before It Begins. And of course,
Oh, I love
that's
that.
in reference to starting before neurodegeneration begins. It will be coming out in spring 2028. So be on the lookout for that. We have a little while to go, but I'm really, really excited because so many questions I'm asked all the time about what I can do, how do I understand my risk, and I can't get back to all of the countless emails and messages that I'm sent. I'm so sorry. So this book is hopefully an effort to really answer those questions and create a landscape for preventive neurology so that it's more accessible to the everyday person.
Mhm. I love that, I love that, and I love your Instagram account, I have to say. Is it
Thank you.
Dr. Kellyann?
Dr. Kellyann Niotis. There is a Dr. Kellyann, and I just wanna say for the record, there's a Dr. Kellyann who sells, bone broth. That is
Oh,
not me.
oh, I don't know about that.
So many people send me, they're like, "I bought your bone broth," and I'm like, "That's not me."
That's funny. I'll be sure to put your, correct hand in our show notes. So I've learned a lot from your Instagram, I have to say, because when a landmark study comes out, and there have been a lot of them over the last few years, something pertaining to dementia prevention or Alzheimer's, FTD, Parkinson's, whatever. I love how you go on Instagram and you explain it before it gets, misinterpreted. I think that's so needed in the landscape right now. So
Thank you.
before we get started, I would love to talk a little bit about neurodegenerative disease in general, because I know that when I started on Alzheimer's education about 10 years ago, people used to say, well, Alzheimer's is really not just one thing. And so with Alzheimer's, there was this feeling that was growing that it was more than one disease. And now I'm feeling like I hear from neurologists that there's a spectrum of across neurodegenerative diseases that have, like you said, similar origins, some overlap in symptoms, and then they start to, branch out from there. So how do you look at the neurodegenerative diseases as a whole? How do you think about it?
Yeah. So for the listeners out there who just want the simple explanation, what is a neurodegenerative disease? Neurodegenerative diseases are there are multiple of them. When I'm talking about neurodegenerative diseases, I'm really focused on the ones that are related to the brain. There are peripheral neurodegenerative diseases. An example of that would be Lou Gehrig's disease or ALS. I'm really focused on the ones that affect the brain itself, which include diseases like Alzheimer's, Lewy body, Parkinson's disease. Frontotemporal dementia is a neurodegenerative form. And what that actually means is that the brain cells are dying or shrinking or atrophying. which leads to a collection of symptoms. How we diagnose neurodegenerative diseases varies based on what particular disease we're talking about. For most diseases, it's really a clinical diagnosis that's supported by some sort of image or maybe a laboratory test, but really the clinical symptoms are what define the disease. So, when we think about Parkinson's disease, for example, really you don't need any specific test. It's an exam, and you see either a tremor, or you see stiff muscles, or you see slow movements or a shuffling gait, and that really tells you they have the disease. You don't need a specific test to tell you that. And for Alzheimer's disease, while we now have more tests that can clue us in, it really matters what the person's symptoms are. And the primary symptom that we're thinking of there is short term memory loss. But as you alluded to, it is really easy for us to put a disease in a bucket and label it as Alzheimer's. But when we actually look at what studies are showing in terms of post autopsy studies, looking at people after they passed away and actually examining their brain tissue, it's very rare that somebody has one neurodegenerative disease. We actually often see multiple or co-pathologies. So for Lewy body dementia, it's somewhere between half and 70% of patients will have Alzheimer's disease pathology as well, and
Oh, I
vice
didn't know
versa.
that. Wow.
Yes, so there's
And
a
even
lot.
vascular dementia and Alzheimer's overlaps about half the time, is that right?
It depends on what study you're looking at. I've even
Yeah.
seen that number up to 80% of the time that some people with Alzheimer's also have vascular features of cognitive decline in terms of what they see on imaging or on autopsy. So there's a ton of overlap there, which really goes back to that point that I made in the very beginning. It's very rare that we're seeing one disease in isolation, and therefore the drivers of the underlying process as a whole are likely similar and they contribute to each other. A lot of pushback has been placed, I think, on this idea that amyloid causes Alzheimer's disease. People are like, it doesn't cause Alzheimer's, or it does. And there's a lot of confusion in the field on really what the role of amyloid is. In my opinion, it's not necessarily the cause of the disease, but having these neurotoxic proteins there are feeding the process of neurodegeneration. And it's possible that one neurodegenerative pathology feeds into another one. So, really thinking about them way back, way upstream is kind of how we look at them more on this idea of a spectrum, even though later down the road they may have very distinct clinical appearances.
Right. So the root cause could be chronic inflammation of some sort that leads to more amyloid being deposited in the brain. And that could
Potential.
any other type of neurodegenerative disease. Let's talk about genetics. I know you get this a lot, and I hear this still all the time that people think that Alzheimer's in particular and Parkinson's is mostly genetic. And now we have evidence to say that the opposite is true.
So it is clear that genetics play a role in terms of the disease onset for both Parkinson's, Alzheimer's, a lot of other forms of neurodegenerative diseases. And having a first degree relative increases your risk because there are likely other genetic etiologies or genetic causes in there that we don't fully understand. So, without a doubt, genes do play a role. But by no means would I say that for the majority of cases, they are the whole cleared picture. There's only a small portion of these diseases that are truly, truly genetic, meaning someone inherited that gene and they definitively developed it because this gene was so strong or so penetrant. That's probably less than 5% of cases. So for most people, they have a gene that slightly increases their risk, but it's not deterministic. It is important to know that you have that gene, in my opinion, because it likely changes how your disease develops and what your risk factors for the disease are, but it's not a guarantee that you will develop the disease.
Right, right. So let's talk about the deterministic genes. There's an early onset Alzheimer's, correct? And then there's late onset Alzheimer's disease. And then there's a new entity called late late?
Yes.
We don't
There's
need to
so
talk
many
about that,
labels.
that's too complicated. But between the early and the late onset, the early onset is what you're talking about with these deterministic genes.
For most cases,
Mhm.
and we're talking about earlier onset, which is before 65, but it's usually even earlier than that. And these are pretty rare genes. Presenilin 1 or 2 and amyloid precursor protein are the big genes that are responsible for this. I will say, though, that I've seen, quote, late onset Alzheimer's cases related to one of these genes too, which to me actually says that even though someone may have inherited one of these very strongly penetrant genes, there's things that you can do to offset the onset of it or delay the onset of disease. And to me, that's so meaningful. And I think people who are in the young timers community, shout out to them. I think that, there are escapees. There are people with these genes that don't end up developing the disease. And there are people who have defied the odds of when the typical age of onset may be. So it is important to know that.
That is
And
really
then,
oh, that is great news.
and if there's anyone out there that has one of these genes, there's an amazing community of people out there. And I really recommend checking them out because it can be really heavy. And I really think having an amazing community of people to really support you through that is so crucial.
Absolutely. Then with late
Yeah, late
onset
onset.
also has genetic variants, the most common being ApoE4.
Mhm.
And what is your feeling about this gene variant and how it behaves?
So of course, I always say genes are not your destiny. This gene is not your destiny by any means. ApoE4 increases risk slightly for Alzheimer's disease, but it really, again, depends on a lot of other factors. It depends on your sex. It depends on your family history. It depends on a lot of the other modifiable risk factors, which I'm sure we'll touch on throughout this discussion. So people push for like, how much does this actually increase my chances? And I'm never one that likes to look at population based data because I don't think that really helps anyone on an individual level. We can look at that data all we want and give numbers, but they may not be applicable to that actual person that's sitting in front of us. So I like people to not think about those numbers very much.
I love that approach because it's also very anxiety provoking when someone hears that their risk is increased by X amount when it may not even be true, right? And there's things that everyone can do to reduce their risk, whether they have a ApoE4 gene or not, which we can talk about. The Lancet Commission's made that pretty clear. Can we talk a little bit about women and ApoE4 and why women in particular seem to be, I don't know, more affected by this gene variant?
Yeah, it's a really good question that we don't really know the answer to, truth be told. It may have something to do with genes that are inherited along with ApoE4 that sit on the X chromosome that predispose women to laying down more tau proteins. It may be related to hormonal shifts. ApoE4 carriers may be more susceptible to these perimenopausal hormonal changes, but the truth is that we really don't know what it is about women ApoE4 carriers that make them more susceptible to the harmful effects of ApoE4.
Yeah, good area for more research. And this is a hot topic for research, correct?
Absolutely. Women's brain health has become much more of a hot topic, which is great, exciting for us. We hadn't had a lot of research on our brains for many, many years, so it's about time that changed.
Absolutely, absolutely. So we have Alzheimer's, we have Parkinson's, we have FTD, we have Lewy body. FTD is frontotemporal dementia. And then there are other types of dementia that people don't really know about or talk about. Do you want to touch on any of those as well?
Well, there are other forms of dementia that will come up if you kind of do research, or that maybe, unfortunately, some people listening to this have a family member that was diagnosed with. Primary progressive aphasia is another one, which could be related to Alzheimer's or could be related to frontotemporal dementia. And then there are other forms of neurodegenerative diseases like multisystem atrophy and progressive supranuclear palsy. So there are a lot of neurodegenerative diseases. They're just not all as common as Alzheimer's, vascular dementia, Lewy body dementia, Parkinson's.
Mhm. So that's the lion's share of what neurologists are seeing. Now, what would
Yes.
you like people to know about early warning signs? And I know it's different for each of these entities, but we can start with Alzheimer's because it's still the most common. 70%
Yeah.
all dementias, Alzheimer's, is that correct?
Yeah. Well, first, I think for those who don't think about these diseases as diseases that don't affect us until we're older adults. They are diseases that affect actually us in midlife. They start in our 30s, 40s, and 50s for most people who get them. So the time to think about them is really in midlife. One overlapping risk factor or early warning sign for a multitude of neurodegenerative diseases is actually loss of sense of smell. That can be seen in Parkinson's, it can be seen in Alzheimer's disease, and of course, it's nonspecific. As all of us know through the COVID pandemic, we can lose our sense of smell from lots of things, viruses, from sinus infections or sinus surgery, injuries to our nose. But if that has changed for you, it could and you have the right setting, meaning you have a family history, maybe you have high risk genes, that could signify something. I'd also say that so you asked more specifically about Alzheimer's disease.
Uh-huh.
It's really hard because a lot of the symptoms of Alzheimer's disease, it's hard to know, is this contributing to Alzheimer's? Is this a risk factor or is this actually a symptom of it? Sleep disturbances, so people will start to develop insomnia or really fragmented sleep, will they start having short sleep cycles. That could be an early warning sign. And of course, when we're thinking about the actual memory pieces of it, changes in language are often first spotted. So, difficulty finding the right word or really formulating a sentence, using objects in an inappropriate way. Like, for example, not remembering how to use the microwave or actually push the dials to the microwave. These can be kind of subtle changes that people will notice. And it's important, I should say, that usually these cognitive changes are noticeable to people around you. So I don't want people to go home and start freaking out because they can't remember the right word. That's also a really normal part of aging. Um, so just note that if someone else is noticing them, I think it's probably time you get
Mhm.
evaluated.
So it sounds like, short-term memory loss seems really common. A lot of people complain about not finding the right word, like word retrieval, or not remembering someone's name or the capital of Kansas or, things like that. But it sounds like the early warning signs are more along the lines of problem solving. Like if you forget how to make coffee or if you forget how to do something on your phone that you're used to doing or getting lost in a place that you normally would know where to go, that's when people maybe should get evaluated because early diagnosis is important, right?
It is. And going back to the word recall, I also do want to emphasize that just think about it as, is this something that you're using every day? Like, if you haven't thought about this person that you can't remember their name, or this movie or this actor that you haven't thought about, or a restaurant that you went to years ago, those are probably not front of mind. So those are really less concerning. But if you can't, for example, remember your neighbor's name who you have many interactions with, then that's a little bit more concerning.
Mhm. Absolutely, absolutely. And then there's something I've come across lately that I've been wanting to write about called subjective cognitive decline. And I've noticed that it's being used now in some studies to look at this as the very earliest, maybe, symptom of dementia or Alzheimer's. Can you talk a little
Mhm.
bit about that?
Yeah, and in fact, we actually use this in our research as well. Um, and really how it's used in a research setting and even in a clinical setting is for most people who come in with a cognitive complaint, they'll do some sort of cognitive testing. And in people who, it tends to be people who have really high cognitive function at baseline, really high cognitive reserve. They're usually highly educated people. They often ace their cognitive tests because they're really well compensated, but that doesn't mean that there hasn't been a change in their cognition. So they're labeled as cognitively normal, but subjective, meaning they're the ones reporting some sort of cognitive change. And we also have that as a part of our research because those subjective cognitive changes oftentimes do correlate with biomarker changes that otherwise would have been missed, but now we have this ability to test for blood biomarkers for disease. So we actually can see that, well, yeah, while this person is, quote, cognitively normal, there are biomarker changes that correspond with their subjective symptoms and subjective reports. So it's likely a true cognitive change, although they would never meet the criteria for being labeled as something like mild cognitive impairment, for example.
Right, right. I saw that in my mom. It took her maybe 3 different cognitive tests to get a diagnosis of mild cognitive impairment because she aced the verbal portion and she just got through it without being told she has MCI. And so there was a delay in the diagnosis for sure, which maybe closed the door on certain treatments for her. So early diagnosis is super key, especially with the new research going on, showing that some of these medications work better the earlier in the disease process, right?
Yep, absolutely. It reminds me of this patient that I saw and I still see who came in after seeing 5 different neurologists for subjective cognitive impairment. And he's a public speaker, so word recall and speaking fluently was really important to him, top of mind. And he really did notice a change. It turns out, yes, he did ace his cognitive tests. And I could say, I didn't notice anything having a conversation with him, but he did. And sure enough, on his biomarkers, he did have abnormal tau. And I think he probably has something called age related tauopathy, which is another form of neurodegenerative diseases that is really uncommon, but it's pretty much isolated tau. Um, and usually
Interesting.
pretty slowly progressive and related to vascular risk factors. So really, really interesting.
So I think the message out there is to let for our audience to know that if you feel like you're off cognitively, even though your partner might say, "Oh, you're fine," or you go to the doctor and he or she says, "You did fine on your cognitive test. See you in a year." You really have to listen to yourself and know when something is wrong. And sometimes it could be very, very early dementia, right? But it also could be other things that are easily treatable, like depression or anxiety or a micronutrient deficiency, for example.
Yes, and I think it's becoming easier to help in terms of giving people an actual answer now that we do have the availability to do certain blood testing that we didn't have 6 years ago.
Yeah. So can we talk more about that, about the
Mhm.
new blood testing, Alzheimer's, such as the p-tau 417, and there's a handful of them now, correct?
217, yes.
17. Thank you.
Yes.
Yeah. So
Um,
how do you
so
use this? How do you use this blood test in your practice?
So, first and foremost, these tests are not approved for use in people who do not have cognitive symptoms. And it's really for good reason because for most of these tests, they haven't been studied in any robust way in people without cognitive symptoms. We don't know when you're giving these normative lab ranges what it means to be like where you should be if you're at risk, for example, versus cognitively impaired. So there's a lot of um, there's a lot of lack of understanding in terms of how to use these biomarkers in people who aren't cognitively impaired. So for most people, they'll go into the office and they'll say that they have subjective or they'll have cognitive symptoms, and one of these blood tests can now be offered, which is great. There's lots of different companies that you can get testing from. They all have different sensitivities and specificities and accuracies. There's a lot of different assays out there, and it's probably beyond this discussion, but I'm happy to talk to you about that if you ever want to dive deeper. Um, So that's possible. When thinking about using them, and I do use blood-based biomarkers in people who are at risk, I use them longitudinally. I don't think using them as a snapshot in time is really helpful because you really want to see the trends of these things over time. And you really want to make sure you're carefully controlling for a lot of external variables that can impact the results and accuracy of the test. So, for example, when we test for amyloid proteins, they're very temperature specific. So they have to be handled in a very appropriate way, or else we'll get false positive results or falsely low, which actually is positive, because the actual amyloid proteins will form films on the test tubes instead of staying constituted in the sample. So there are a lot of nuances there. And I think we're trying to pioneer this with our research. How do we give people a better understanding of what normative ranges should be for quote normal people and what an at risk range for various biomarkers should be? And how do you use those to help guide management? Because that is the key. Like, how do we know what we're doing is actually impacting the individual in front of us, is actually impacting the underlying disease? We had no good way of knowing that until the last 6 years. So now we actually have tools to measure our outcome. And I think that is so exciting. And that's why I'm so optimistic about
Oh,
where the field is
fantastic.
going.
I'm so glad you're optimistic about this because I've been seeing things like p-tau included in lifestyle intervention trials, like you said, longitudinally, not just as a snapshot in time, but to see how someone's brain is actually responding to an intervention, whether it be
Mhm.
exercise or a brain healthy diet or more social connection or more stress mitigation, all of these really important things. So it's an
Yes.
important piece of the puzzle.
Definitely. And, before we only had really cognitive function or MRI imaging to really tell us how is someone responding to certain interventions, but that doesn't necessarily tell us how the underlying disease is behaving. So this is really an exciting field and it's really evolving quickly and there's truly so much research that I can't even keep up with it every day.
I bet, I bet. So what are some of the other biomarkers that you rely on when you have someone in your office who has subjective cognitive decline or is showing overt signs of cognitive decline? For example, what do you think of inflammatory biomarkers like homocysteine or high
Mhm.
sensitivity C-reactive protein, things like that?
So there are We can label these in two buckets. There are the biomarkers that are related to actual neurodegenerative disease pathology, which would be things like amyloid beta 42/40 ratio, p-tau 181, p-tau 217, NFL, GFAP. These are kind of more related to intrinsic what's happening in the brain. And then we have peripheral biomarkers, which tell us about modifiable risks. So those things we'll look at vascular risk factors like someone's ApoB or their LDL cholesterol. That, of course, is an important thing to follow. We'll look at renal function, so things like cystatin C and creatinine and how well the kidneys are filtrating or their GFR. That tells us a lot. You mentioned homocysteine. That can also be really helpful. We know that people with elevated homocysteine levels have increased risk of brain atrophy. It seems like homocysteine is directly related to that, and it's often an inflammatory marker that's related to B12 or B vitamin deficiencies. So checking our B vitamins, which neurologists love checking B12. That's our favorite that's our favorite vitamin, period. So that one
Oh,
is
I
of
love
course
it.
really,
Your
really
favorite vitamin of the neurologist because it must be so
yes.
gratifying to actually find one of these micronutrient deficiencies and correct it.
Yeah, I mean, it's really funny. We always joke. The neurologists in general don't have a lot of tools in our toolbox. We have an EEG, an MRI, and then we have a spinal tap. Those are pretty much all we ever offer. And then there's labs that we always want checked. So we always want a thyroid checked. We always want a B12 level check and syphilis because you never know who is getting syphilis these days.
This is true, this is true. Yeah, these infectious diseases are gone, but they're not. You
Yes.
they keep rearing up. Um,
But all joking aside, I'll also add that high sensitivity CRP, I think you mentioned, is another really important one. It is a non-specific marker for inflammation, but it can tell us if there's general inflammation going around or going on, and if there's some area that we should maybe look into a little bit more closely, whether that's an autoimmune process or an oral abscess. You never know what might trigger someone's hsCRP to be elevated, but high peripheral inflammation, especially in ApoE4 carriers, is linked to a higher risk of Alzheimer's disease. So that's another one to think about.
Okay. And then let's talk about LDL and lipids. I've actually learned so much from you about the lipidology and how it relates to the brain. And, it's very exciting to see this area of science really evolve. So, LDL was just added, low density lipoprotein, cholesterol was just added as a risk factor for dementia by the Lancet Commission at the end of 2024. And we've known for a long time that elevated cholesterol is associated with dementia, right? So, could you just give us sort of the lay of the land on the importance of lipids?
Yeah, I mean, this is a loaded topic, and clearly I've spoken about this for 2 hours, so I might need to be cut off. It might just be me, or it might be true that there is a lot more interest in central lipids, so we understood a lot more about how peripheral lipidology worked, but very little about brain lipoproteins and brain lipids. So this field is definitely evolving, but it's so important because when we think about ApoE, apolipoprotein E, it is a lipoprotein. It's a cholesterol transport protein. So it's mind blowing that, neurologists aren't really ever taught about lipids because they really are so critical to how the brain functions. So going back to LDL, I think what a lot of people don't understand is that although LDL cholesterol is a modifiable risk factor for Alzheimer's disease, it doesn't have anything to do with the brain's cholesterol. It is really a peripheral risk factor. And the way that elevated LDL cholesterol increases risk or can contribute to neurodegenerative diseases is through laying down atherosclerotic plaque and causing systemic inflammation that changes the way the brain is getting adequate oxygen and adequate blood flow. Um, that isn't changing necessarily anything in terms of the brain's ability to produce cholesterol or synthesize or transport cholesterol. So I think there is a big misunderstanding in terms of people not understanding how someone's peripheral levels are related to the brain and so forth. So hope to clear that up for some people.
Right. So having a high LDL cholesterol is a risk factor because of all the things we talked about in the beginning in terms of vascular problems leading to narrowed blood vessels in the brain and this overlap between vascular factors and Alzheimer's and Lewy body. It's not that the cholesterol is crossing the blood-brain barrier because the brain has its own cholesterol factory, right? It makes all the cholesterol it needs. There's
That's
no
correct.
mixing
Exactly.
cholesterol from the peripheral to central. So, it's very exciting, like you said, this new research in central cholesterol in the brain, like desmosterol. Like, how do you
Mhm.
think about desmo levels and when do you check that? And what is your thinking about how that contributes to the overall presentation of Alzheimer's, for example?
So again, a lot of this is really theoretical because we don't really know yet. So we're just basing this on the studies that we do have. What studies have shown, so the brain synthesizes its own cholesterol. There are complicated pathways by which the brain will synthesize cholesterol. Its primary pathway is one that takes a precursor molecule called desmosterol and it converts it into cholesterol in the brain tissue itself, specifically in the astrocytes. Desmosterol is also produced by the liver, so it's not only specific to the brain. However, there have been studies that look at levels of desmosterol that are floating around in our blood and levels of desmosterol that are floating around in our CSF. And they actually do correlate pretty well. So, what's happening in the CSF tends to mirror what's happening in the plasma. So, that's great. What These studies also show are that people who have mild cognitive impairment and then Alzheimer's disease start dropping their levels of desmosterol, which signal that cholesterol synthesis in the brain is starting to become disrupted in some way in people who go down the path of Alzheimer's disease. So, in theory, desmosterol might be a really good marker to tell us what's happening to brain cholesterol synthesis. But like I said, it's a little bit limited in that it's not specific to brain cholesterol synthesis. There is another marker, 24 hydroxysterol hydroxycholesterol, or 24-OH. This one is specific to the brain's ability to produce cholesterol, and it is in the blood, and everything that we see in the blood is coming from the brain. So that's really exciting. It's not available. I can't order that test on anyone. So one day I hope to be able to order that test and kind of better understand how someone's brain is producing cholesterol. But what is the significance of this in a clinical setting? Well, one potential significant way to use this is understanding someone's risk. Another potential way to use this information is when we're thinking about treatment for LDL cholesterol. There are lots of options that we have, and almost all the studies we have show that statins are probably the way to go, and they're usually the medication of choice, usually what most physicians will use as their first line therapy, and that's often the right approach for most people. But it's possible that for people, for various reasons, based on their intrinsic biology, they may not do well on a statin. And it may actually overcompromise cholesterol production because statins block production of cholesterol. They block it primarily in the liver, but they also can block it in the brain. So it's possible that the statins can overdo it for some people. In some people, that actually might be desirable because the brain may be making too much cholesterol. In other people, it may be less desirable. So it really is not a one size fits all. And that's what makes this field so fun, but also so challenging.
And it gets super complicated, as you can see. And, I think it sort of drives home the point where, thinking about your heart and your cardiovascular system is paramount for preventing dementia 20, 30 years down the line. So let's go over some of the things that people can do to actually reduce the risk of developing dementia. And I know lowering LDL is one. So in order to do that, first you have to go get a lipid profile, right?
Yes. Yes.
And LDL has been the standard biomarker for a long time, but now a lot of people are saying that ApoB is just as important, maybe not even a better marker for elevated cholesterol.
ApoB has is more well known in the field of cardio disease or cardiology. Neurologists are less likely to report on ApoB, which is why we kind of see this discrepancy. Neurologists really do focus on the traditional lipid measures because a lot of that research is what we have. But in fact, ApoB is actually the atherogenic particle that makes the LDL cholesterol sticky and get caught in our blood vessels of our neck, of our brain, of our heart, and leads to issues. So it's really a better marker of how likely your LDL is to cause issues. So it's probably a better test, and we should
Mhm.
be using it more.
So that's another
But
thing people can ask for if it's not included in
yeah,
their lipid profiles, maybe ask for an ApoB.
yeah, and it's a really inexpensive test.
Mhm. And then I
Um,
hear a lot from people that they have been told they have a high LDL, but they also have a high HDL, and so they've been told that that's okay. They balance out. What do you think of that in 2026?
Yeah, so while it helps a lot of people understand good and bad cholesterol, it's really not great to use those terms for LDL or HDL cholesterol just because HDL got this nickname as good cholesterol because its role is to kind of float around in our periphery and suck up cholesterol and bring it back to be recycled. So it does a good function, but having high levels doesn't actually mean that the HDL that's floating around is actually doing that job. It could be not functional HDL. So it's important to know that actually having high HDL, and I'm one of these people, so it's heartbreaking that I like wish I could just say I have great HDL, so my cholesterol is perfect. But unfortunately, people with high HDL, we now understand have a higher risk of cardiovascular disease as well. So we stopped using good cholesterol for HDL, and if any doctors are telling you that, unfortunately, they have a little bit outdated information. So double check that.
Yeah, good to know, good to know. It is a little bit too simplistic. I mean, the lipidology is super complex. We're just starting to learn how it applies to brain health. I mean, all of these things are fairly new in the last few years. So, but people can go and get their lipid profile done, ask for an ApoB, and what else can people do? What about hearing? What about getting a hearing?
Mhm. Hearing and vision are absolutely necessary. I would say that if you've not ever had your hearing checked after the age of 45, you should at least get a screening. Um, Most of hearing loss is entirely in our control. It's exposure to loud noises. So think about protecting your ears just like you think about protecting your skin. Anytime you're going to be exposed to excessive loud noises or excessive sun, you're going to put on sunblock. Excessive loud noises, you're going to want to use some sort of hearing protection. Um, and starting with a baseline hearing screening can be really helpful because it shows you where you are now and gives you something to follow. And we do understand that hearing aids actually reduce the risk of reduce the risk of Alzheimer's that's associated with hearing loss. And hearing loss seems to be, at least on a population level, one of the primary drivers for dementia. So it's an absolute necessary step to get your hearing checked. And along with that, getting your vision checked. So having good senses, whether that's hearing or vision, likely are providing some sort of sensory input to the brain that's keeping it active and healthy. And vision is another big source of that. So early visual impairment should really be treated early.
And these sound like such low-hanging fruit, but there's also stigma to losing hearing as one gets older. Some people don't even wanna go in and get the test done.
I know. I
Yeah,
know.
so changing that stigma is a big part of this. And what do you think is going on in the brain with hearing loss and also visual loss? Is it something that's happening in the brain, or is it that people tend to become less social when they can't hear or see as well, which we also know is a risk factor? Loneliness, social isolation are both risk factors for dementia.
I think, as you said, it's likely both, and we don't know the true answer, but of course, not hearing, not seeing put you at risk of isolation and loneliness and lack of social engagement. But it's also true that where hearing is processed in the brain is the temporal lobe, and that happens to be the area that's impacted by Alzheimer's disease. So there's this idea that the brain is a very use it or lose it organ. It needs a variety of sensory inputs to keep it happy and healthy. And sensory inputs come from our hearing and our vision and our peripheral nervous system. So feeding those neurons in that area of the brain are keeping it active. And our vision is processed in lots of regions, but one primary region is the back of our brain called the occipital lobe. That region's heavily impacted by Lewy body dementia. So if
Yeah.
these are risk factors for you, making sure that those senses are as healthy as possible is really important for your brain.
I have to say, when I went and got my hearing checked, it was very empowering. It was really a wonderful thing to get it checked in detail and know exactly where I stood for my age. And I felt it. I felt like it was a very positive experience. Very positive.
Yeah.
So definitely, people need to get their hearing checked. I know that it's not covered by insurance often until I don't know 65. Is that correct? So maybe one of those
Insure.
tests that you go in and you ask for, and you do even if your insurance doesn't cover it because it's that important.
For most of these hearing tests, you actually don't even need insurance. You don't even need a referral. Um, you can make an appointment with an audiologist yourself, and there's actually even some online testing to do vision and hearing tests. They're not perfect,
Mhm.
but they're better than nothing.
Absolutely better than nothing. Okay, what else can we do? I know there is a big category of metabolic health as it feeds into dementia. This is the tendency for people to become insulin resistant or pre-diabetic or have elevated blood sugars as they get older? What can you tell us about being on top of this risk factor?
Yeah, this often starts much earlier than the labs will indicate. Um, so a lot of people will walk around for years with a normal hemoglobin A1C, which is a marker of your glucose, your average glucose control over the course of 3 months. That can be misleading, or it can be like in this borderline zone and really go dismissed for a long time. So I would say if your hemoglobin A1C is really over 5.6, then you should really take that more seriously because you are probably insulin resistant. Looking at fasting glucose levels can be really helpful. So, really, anything above 90 is a high fasting glucose. And fasting insulin levels can also be helpful. Anything over 10 can be indicative that your pancreas is working really, really hard to keep your blood sugars at the level that they're at. And eventually, your pancreas can become tired. And that's kind of how diabetes starts to form. And metabolic health is really tied in a lot to body composition. So it's important to kind of bring these two together and unite them and understand them collectively. People with elevated visceral adipose tissue, which is fat around the organs, tend to be at a higher risk for insulin resistance. But I also want to note that while this isn't in the Lancet Commission's modifiable risk factors, I truly believe it is one. Having low muscle mass is just as detrimental, because muscle is our glucose sponge. It sucks up all of the glucose that's floating around and it doesn't need insulin to do that. So if you are adequately muscled, your glycemic control is much better. So those two really go hand in hand.
I'm so glad you brought that up because, what we're talking about is the Lancet Commission's 14 modifiable risk factors. It's a statement based on, a group of Alzheimer's experts around the world who look at the most rigorous studies and agree that, this factor like visual loss or elevated LDL contributes to dementia. But there's things that aren't on there that anyone who knows about brain health would see. Like, for example, there's nothing about brain healthy eating. There's nothing
Mm-mm.
about muscle mass. There's nothing about sleep. And I mean, my theory has always been that they just don't have the rigorous data, or maybe the data is just not there yet. Why do you think these pillars of brain health are just not recognized as modifiable risk factors?
I think that, so let's start with sleep. Sleep is a huge category. I think it's more likely that we'll see certain sleep behaviors like sleep apnea added to this list. Like you heard it first here, it will be added to this list of modifiable risk factors eventually. But just quote insomnia is really hard to put as a risk factor because, as I said, it's a chicken or the egg situation. People
Right.
who are prodromal or preclinical, which I don't like that word, but who are maybe on the path to developing Alzheimer's, develop insomnia. So is it a symptom of early disease or is it a risk factor? I believe it's both, but it just becomes very, very hard to sort that out in studies that would take 20 to 30 years. And then the same is true with diet. Diet is, as you know, you don't need me to tell you, one of the most challenging things to study because it is so multifaceted. It is so hard to control what somebody's eating. And most of these things are based on self reports of food and food frequency questionnaires. And it's really, really challenging. I mean,
Observational data.
a lot of, but it's clear that all of the evidence out there really pushes towards this Mediterranean mind-based diet eating. I think that will be added to this list at one point, but
Oh my
I think
gosh,
that
that
one's
would
a
be that would be something. I would
right? I mean,
I would
it
be so
should be.
happy. But you can see the
It's
intersection of where nutrition plays into the other risk factors like metabolic health, like LDL cholesterol, even hearing and visual loss. There's an argument for a brain protective diet to protect the neurons, for your vision and hearing. Even things like loneliness and social isolation, there's a food piece. So I can see it feeding in at multiple levels, but it sure would be nice for it to be recognized as its own.
I mean, if they were able to say low physical activity is a risk factor, then I think unhealthy eating habits or poor nutrition. I don't know how they would word it as a risk factor, but it's hard to dismiss it,
Right.
and
Nutrient poor
anyone
diet. Yeah. I mean, we know that 60% of the calories in the United States come from ultra processed foods. That's a nutrient poor diet that puts people at risk for
yes,
changes. And we know this
yes.
already. We know this. So the takeaway from all of that, well, number one is get a sleep study if you don't have adequate sleep, if you have any
If
issues,
you're snoring if
sleep
you're
apnea is
snoring,
so common, right?
it is incredibly underdiagnosed. I'm shocked how often sleep apnea pops up when we do sleep studies in people who maybe their spouse or bed partner will say like, "Yeah, you do snore occasionally." And sometimes it's not just snoring. You can have less obvious breathing pattern disorders that do pop up on sleep studies, and they can be related to anatomical issues. We classically think of sleep apnea as somebody that's overweight, that has a very large neck girth that will collapse when they lay flat. But a lot of the people that I'm seeing are don't fit that category. They're people with nasal surgeries or deviated septums or some sort of anatomical issue that's leading to a similar obstructive picture. So I do think that getting that screening is really, really important if you do notice that your sleep is just not restorative.
And are the studies supporting, when you treat sleep apnea, it improves cognitive function? Do we have good data on that yet?
I
Still
don't know
working.
that we have great
Yeah.
data on it, but I believe that it is.
The patients probably tell you that they're thinking better because they're
Oh
sleeping better.
yeah. And that
Fundamental.
they're exercising better. Like it just impacts so many different that their blood pressure is better. It just really does impact so many other aspects of brain health.
Okay, well, before we move on, are there any other Lancet Commission risk factors that merit more discussion?
Um, I guess the other big one that is worth discussing is alcohol, just because it's so pervasive in our life and our social interactions with people. And a lot of people ask me, like, is all alcohol bad? Should I never drink alcohol again? And I'm not gonna take anyone's fun away. That's not my goal. I want everyone to really enjoy their life and make this fun. I don't think any of it's worth it if you can't enjoy your life, but I do think if you have an unhealthy relationship with alcohol, meaning you're using it as self-medication, I think you should really, like, dig into that relationship a little bit more deeply because if there's something else there, that's worth treating, like anxiety and depression. There are other ways that we can do that, and again, that matters to your brain health.
Mhm. Well, so it's a good point. Also, we used to think that a little bit of alcohol was probably not that bad for the brain, but all of that changed back in 2021 because, the UK Biobank study came out, another study in the British Journal of Medicine came out showing that even small amounts of alcohol are detrimental to long-term brain health. I know because I was writing the drinks chapter of my book at the end of 2021 when some of these studies came out, and I completely changed what was in my book and took, red wine famously was part of the Mediterranean diet. It was one of the 10 brain healthy food groups in the MIND diet.
Mhm.
Right? And so, I called my editor and I said, "I need to change the whole drinks chapter, and I need to take red wine and take it away from the brain healthy groups and put it in the foods to limit or avoid because this data is just very strong. We can't ignore it no matter how much we would, enjoy having a glass of wine whenever we feel like it." So, yeah, people do need to be aware of it. I completely agree. Yeah. Okay, so if you have a few more minutes, I would love to get your take on some like wellness trends that seem to be
Okay.
like very pervasive in a lot of the social media accounts that I follow, and probably you do too. So I would just love to hear your expert opinion on a scale of 1 to 10, the benefit of this as it pertains to your brain health.
Okay.
Either
10 is very beneficial.
10 is like a no brainer. Yes, I would do that. One
Okay.
is that's a waste of time.
Okay.
Okay. All right, you ready?
Mhm.
Sauna.
I'll give sauna a 7.
7 is good. Yeah, especially if you
7 is
enjoy
good.
it.
Mhm. For lots of reasons, relaxation, potentially heat shock proteins. I think the elevation of heart rate, I think a
Mhm,
7.
I like it. Cold plunging.
For brain health, a 1. No evidence that it helps your brain at
No.
all. Maybe it'll help acute clarity and, like, help you feel better in that moment, but it isn't going to do anything for long-term brain health.
So if you enjoy it, do it,
Great.
and if you don't have to cold plunge.
Yes.
I actually love cold plunging in the lakes and the mountains where I
I
live.
like it. I like it too. I totally enjoy it, but you don't have to do it because it's not gonna prevent dementia.
Yeah. Okay. Okay, this one I see a lot where I live. It's very, very trendy. NAD+ infusions.
Yeah. I also see this a lot. Very, very trendy. I'm, like, debating another one on this. I don't think that there's really any compelling evidence to use it, and when people ask me, I say it's not gonna hurt you, but it's likely not going to do anything for the big picture.
Mhm. Yeah, agreed. What about creatine?
So I'll put that one in the 5 to 6 category. Likely beneficial for muscle building, potentially beneficial for acute cognition, especially in people who are vegetarians. Is it going to improve long-term cognition? Does it reduce risk of dementia? Not sure about that.
Yeah, remains to be seen. Promising.
Mhm.
Promising.
Promising.
Okay. When it comes to exercise, what about high intensity interval training or HIIT?
I'm gonna put that up at the 9-10 place because that high intensity work, even if you're doing it once a week, is really giving your brain so much blood flow, stimulating so many neurotropins like BDNF and irisin, and all of those things are protective for your brain. So, yes, if you're going to spend your time on cold plunging, then you also have to promise you're going to do some hit work.
Fantastic. Yeah, that's how it works. B vitamins. I think I know what you're going to say about these.
Yes, 10, 10, 10 for sure. We love B vitamins.
What about weighted vests?
I saw a lot of very funny Instagram videos on weighted vests. um, so uh, I'll give them a 3.
Okay.
I Sure. Are they potentially helpful for loading your muscles? Sure, but not as great as actually doing weight training. And there's probably not a lot. I mean, there isn't any evidence that it directly is going to impact long-term brain health, but in terms of evidence of putting on muscle mass, which impact brain health, we'll put it at a 3.
Yeah, maybe bone, maybe muscle, but remains to be seen. Okay.
Yeah.
What about red light therapy?
Again, great for your skin, does not do anything for the brain. So I'm gonna put that at a 1.
Peptides?
Again, I'm gonna put it, like, negative, like 0, because I'm terrified of the things that people are getting injected into them and what I've seen in their blood work after they've gotten these various infusions. I am not saying that there aren't people out there who are extremely skilled and know exactly what they're doing and know what they're mixing with their peptides, but I've seen a lot of really scary things happen. So I think for most people, it's best to stay away from it.
Yeah, every town now has like an IV infusion center, like a wellness center. We can go and get these things injected into your IV. It's mind-boggling how there's no data on this being helpful, right?
A and what are they injecting in you? Do you actually know?
Well, there's a menu. You can get NAD+, you can get
But
peptides, but like, how
you're
do you know what it?
trusting.
How do you know?
Yes.
It's not like it's a drug that says on the label. Okay, we
It's not regulated in any way.
okay. What about this one? Might be slightly better. Lion's mane mushroom or extract.
So I'll put that in, like, the 3 to 4 range. There's actually some data that shows that it may help acute cognition, small data may prevent some sort of dementia, but nothing really robust. And a lot of it is unfortunately industry sponsored studies. So you always have to be careful with that kind of stuff,
Mhm.
but potentially helpful, likely not harmful.
Okay. Couple more. This one's really important because there was just a big study. I learned about it on your Instagram. Brain training or brain games.
So depending on the brain game that you're doing, it can be high. So we can give it a 10. But I also want to emphasize that a lot of people are using a lot of different types of brain training, or they're doing Sudoku or crossword puzzles. And honestly, there's not a ton of data that that stuff is going to actually protect your brain or build cognitive reserve. I think the best thing that people should do is really just challenge their brain, do different activities, experience different cultures, go to museums, learn new things. That's really where it comes in. And if you're going to sacrifice the specific type of brain training, which the study showed the specific test called the double decision test from Brain HQ, may be beneficial for long term brain health. If you're going to do that, you also should exercise because that's also building up reserve.
I love it. I love it. Okay, last one, omega-3 fatty acids.
I'm gonna give this one a solid 9. I think they're really, really important. I don't think we have perfect studies on it, but I believe that they're really important for brain health.
I know I'm writing about omega-3s right now for my Substack and delving into, the vast array of data. I know I just wish it was stronger, but the biological plausibility of how omega-3s work in the brain is so strong and
Mhm.
observational data. So we'll get the proof. We'll get the proof. It just may take some time.
Yes. Yes.
Well, Kellyann, you are an incredible wealth of information. I am absolutely over the moon that you are writing a book and that it's coming out soon-ish. And it's going to be a great resource for everyone who has a brain, everyone who has a million questions about this. And I just can't wait. I just can't wait for
Thank
your book to
you.
come out. Yeah.
Thanks so much for having me. Thank you for your thoughtful questions.
Oh, it's been a pleasure. And in the meantime, where can we find you and learn from you?
So you can visit me at my Instagram. I do post content. I try to post it regularly, but I do post high quality content. So it's
Yeah.
not, I'm not spamming you. Which is at Dr. Kellyann Niotis, and then my website, which is also drkellyanniotis.com. And then if you're a professional and you want to connect on LinkedIn, please reach out. I love connecting to other providers who are interested in this space.
Fantastic. Fantastic. Well, thanks for taking the time. And I look forward to talking to you again.
Thank you. Thanks for having me.
You bet. Bye bye.
Bye.
I'm so grateful to Dr. Niotis for sharing her research and advice. I'm now joined by my co host and producer, Jenny Schilling. Hi, Jenny.
Hi, Annie. That was an incredible conversation. Dr. Niotis manages to make dementia prevention feel both more precise and more hopeful.
Yes. And I can't wait to hear your takeaways.
One of my biggest takeaways is that neurodegenerative diseases don't usually begin when symptoms appear. Alzheimer's, Parkinson's, Lewy body dementia, and related conditions often start developing years, even decades earlier. And that means midlife is not too early to think about prevention. In fact, it might be a really important phase. I also appreciated her point that these diseases are rarely as cleanly separated as we tend to think. Someone may be diagnosed with Alzheimer's, but also have vascular changes, Lewy body pathology, or other overlapping processes happening in the brain. That matters because it shifts the focus upstream towards the shared risk factors we can actually do something about. Another key takeaway is that genes matter, but they are not destiny. Even genes like ApoE4 may change someone's risk profile, but they don't guarantee that you'll get the disease. Dr. Niotis made the case for understanding risk in a more individualized way, instead of relying only on broad population statistics that may not apply to the person sitting in front of the doctor. We also talked about how early warning signs can be subtle. It's not just forgetting a random name or misplacing a word. It may be changes that other people in your life notice, like difficulty doing familiar tasks, or changes in smell, sleep disruption, or a sense that your cognition is different even when standard testing still looks normal. And finally, I thought the biomarker discussion was fascinating. We're entering a new era where blood tests, lipid markers, inflammation markers, metabolic health, hearing, vision, sleep, body composition may all become part of a much more personalized picture of brain health risk.
Yes. And what I love about Dr. Niotis' approach is that prevention is not one thing. It's not
Mhm.
one supplement, one lab test, or one wellness trend. It's the whole picture of how we care for the brain over time. So here's how we put this into action. Get your basic biomarkers checked, including lipids, blood sugar markers, B12, thyroid, and inflammatory markers when appropriate. Ask your doctor about ApoB, especially if you have elevated LDL cholesterol or a family history of cardiovascular disease or dementia. Take metabolic health seriously. If your fasting glucose, fasting insulin, or hemoglobin A1C are creeping up, don't wait until you have diabetes to make changes. And then this is a big one. Build and maintain muscle. Muscle helps regulate blood sugar, supports metabolic health, and is one of the most important investments we can make at any age. Get your hearing checked, ideally starting in midlife. Hearing loss is a major modifiable risk factor for dementia, and treating it matters. In the same vein, get your vision checked regularly. The brain depends on sensory input, and untreated vision changes may contribute to cognitive risk. Pay attention to sleep. If you snore, wake up unrefreshed, or suspect sleep apnea, ask about a sleep study. Limit alcohol. We've been talking about this throughout the podcast, right, Jenny?
Yeah, we
Especially if you,
have.
yeah, especially if you drink regularly or using it to manage stress, anxiety, or sleep. Be cautious with wellness trends. Some things are promising, some are harmless but overhyped, and some, especially unregulated injections or infusions, may carry real risk. And most importantly, if you feel something is changing in your cognition, listen to yourself. Even if a brief cognitive screen looks normal, persistent concerns deserve thoughtful evaluation. Early detection gives us more options, more time, and more opportunity to intervene.
That's a great to-do list for us. And I would encourage everybody to share this episode with somebody you love who is a little concerned with declines in their cognition.
Yeah, if you know someone who's worried about their memory or having cognitive slips, please share this episode with them. Thanks for joining us on the Brain Health Kitchen podcast, and we'll see you next time. I write about brain healthy eating every week. I talk about it on this podcast, and I wrote the book literally on brain healthy cooking. But it wasn't until I went through the Better Brain program that I made important changes to what I was doing day to day, like a B vitamin absorption issue I never knew I had, and a slight uptick in my cholesterol, to name a few. Now I'm already starting to see improvement in my brain health biomarkers, thanks to our founding sponsor, Better Brain. They provide a science-backed brain health lab panel and expert coaching. Most people pay $0 out of pocket for these sessions. Check it out at betterbrain.com/Annie and build your personalized brain health action plan covered by insurance. I'd also like to thank NeuroReserve for being a founding sponsor for this podcast. Check out their brain health nutritional products like Relevate, Brain Health Kitchen Extra Virgin Olive Oil, and Revanta Creatine. I've known the NeuroReserve team for many years, and I also use their products as part of my own brain health care routine. So go on over to neuroreserve.com and use code BHK podcast for 10% off. The Brain Health Kitchen podcast is for educational and informational purposes only. The content shared on this podcast, including conversations with guests, is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed by guests are their own and do not necessarily reflect the views of the Brain Health Kitchen podcast or its hosts.